All right. Good afternoon, and thank you all so much for participating in this year's Developmental Screening Summer webinar series. We have made it to our last session, so thank you all so much for your participation. My name is Dr. Teresa Northington, and I am the Developmental Screening Coordinator for the Bureau of Family Health. And it is my great pleasure once again to introduce our session today, which is supporting patients with perinatal depression, effective strategies for healthcare providers. Before we begin, I will read the disclosure statement from Dr. Finelli. Here we go. And it says Juliana Finelli has disclosed that she has no relevant financial relationships. All remaining faculty, Louisiana AAP Education Committee members, and staff have no relevant financial relationships to disclose with ineligible companies whose primary business is producing, marketing, selling, reselling, or distributing healthcare products used by or on patients, and all relevant financial relationships have been mitigated. If you are, before we begin, if you are a participant who is a social worker, registered nurse, nurse practitioner, or physician, and you would like to receive CE or CME credit or contact hours for attending this session, please be advised that you must attend the session in full and complete the evaluation at the end of the webinar. Okay, so today's speaker is Dr. Juliana Finelli. Dr. Finelli is a board-certified general psychiatrist and certified in child and adolescent psychiatry. Her academic and clinical interests focus on infant and early childhood mental health and perinatal psychiatry. She serves as the medical director for the provider-to-provider consultation line, also known as PPCL, and supervises residents, fellows, and medical students at the Tulane Mental Health Services at Metropolitan Human Services District. Without further ado, Dr. Finelli, I pass it to you. I'll take my slides down.
Thanks so much, Dr. Northington. Good afternoon, everyone. I'm going to share my slides quickly. Go. And I apologize in advance. I'm dealing with a little cold today, so apologies in advance for my voice. I will do my best. So we're going to be talking today about strategies for supporting parents with perinatal depression. We'll talk a little bit about perinatal mental health in general, what some of the care gaps are, and we'll be focusing on the birthing parent, but there's going to be some parts during this presentation we'll talk about the non-birthing parent as well. So we'll talk about the perinatal mental health gaps that exist and the rationale behind guidelines from organizations like the AAP, the American Academy of Pediatrics. We'll talk about some of the screening tools that are validated for use in the perinatal population. We'll talk a little bit about strategies for incorporating this kind of screening into pediatric practices, as well as some approaches for supporting families who are impacted by what we call PMADs, perinatal mood and anxiety disorders. And then finally, we'll talk a little bit about resources in Louisiana that clinicians and families and other people who care about children and their families can make use of. So a little bit first about perinatal mental health care gaps. Mental health problems are actually the most common complication of pregnancy, and that's compared with other complications we more commonly think about, things like gestational diabetes, things like hypertension, all very concerning complications that can happen in pregnancy. But taken as a whole, mental health problems are actually the most common complication. They impact up to 20% of women in the perinatal period. This percentage is likely higher among women who are low income or women who are minority patients. Despite how common perinatal mental health problems are, they're definitely underidentified. So studies that we have suggest that less than half of women who are experiencing perinatal mental health problems are identified by their frontline healthcare physician or clinician. And even when they are identified, they're undertreated. So studies suggest that 75% of patients experiencing perinatal mental health symptoms go untreated. And the fact is there are simply not enough psychiatric providers to care for all of the patients who have perinatal mental health issues. It's a real care gap that we have. And finally, pregnant people are underrepresented when it comes to both clinical research and clinical training. So, because of historical restrictions, and historically pregnant patients have been considered what's called a vulnerable population in research, in the same category as we put children or individuals who are incarcerated. Because of that, we have a lot of limitations on the amount of research data we have on any kind of medical interventions, both efficacy, side effects, risk to the fetus. So well-meaning restrictions on research and ethical concerns have actually made it harder for pregnant people to get the information they need to make decisions about their mental health. And clinical training, we have gaps as well. It surprises some folks outside of psychiatry to know that psychiatry residents in training actually aren't required to demonstrate competency in treating pregnant perinatal populations. And often that means that there's a training gap as well. So all of these are significant gaps that we're dealing with. And this is despite the fact that we know that perinatal mood and anxiety disorders impact not just one, but two generations. I won't go through this whole list. I think many folks are familiar with this, but research suggests that perinatal depression in particular, but also perinatal anxiety, impact pregnancy outcomes, obstetrical outcomes, breastfeeding, rates of breastfeeding and breastfeeding persistence. There's an increased risk for co-occurring substance use, which is associated with negative pregnancy outcomes. And then all the way through to looking at parent-child interactions. We know that those can be impacted by postpartum depression. And I'll add here, we also see this in the non-birthing parent and in dads who have postpartum depression as well. Higher rates of negative parent-child interactions, higher use of physical punishment, including in very young children. And we know that those first few years are critical when it comes to brain development. And so much of that is dependent upon early relationship experiences with primary caregivers. So it's for these reasons and because of these care gaps that the American Academy of Pediatrics recommends screening for postpartum depression specifically. And they recommend screening at the 1 month well baby visit, the 2 month, the 4 month, and the 6 month visit. Um, Also, the AAP recommends a psychosocial assessment at every visit with particular attention to poverty and mental health. And when it comes to screening for maternal depression and addressing maternal and parental depression, the pediatrician's role is often one of screening, identification, and referral to services. When the pregnant or the postpartum person is the patient, for example, the case of an adolescent or young adult who's pregnant and is seeing their pediatrician, the pediatrician's role may include implementing a first-line intervention as well. And the reason why we recommend screening at multiple dates in the postpartum period, number one, postpartum depression can present at any point in that first postpartum year. This study actually found a bimodal peak, so to speak. So with the highest peak being in that first month postpartum, but also seeing another peak around 9 months. 6 months is often a time when weaning happens, and the hormonal shifts that occur with weaning, decreased prolactin, oxytocin, and increase in estrogen, those hormonal shifts can also create increased risk for occurrence of a postpartum mood episode. So we recommend screening actually ideally throughout that first postpartum year. But this is part of the reason why the AAP recommends screening at multiple well baby visits. So we'll talk a little bit about specific tools, and many folks may be familiar. Um, the two screening tools we'll focus on are the Edinburgh Postnatal Depression Scale. And I'll note it's called the Postnatal Depression Scale, but it's validated for use throughout the perinatal period. That means from conception through that first year of life. It's also been validated in non-birthing parents with depression. Generally, for fathers, it's recommended to use a lower cutoff, a lower screening cutoff. The PHQ-9 is also validated for use in this population. A quick note about the PHQ-2. The PHQ-2, which is a 2-item screen for depression, has not been well validated in the perinatal population. We have some data to suggest that use of the traditional cutoff of 3 misses an unacceptable number of patients who are experiencing depression. So if the PHQ-2 is going to be used, we recommend a lower cutoff. So any score other than 0 should prompt a full PHQ-9, the 9-item screen. I threw some other screens up here because folks often ask what are validated screens for these concerns: anxiety, bipolar disorder, and PTSD. I want to note again, all of these are screens. Screens are not diagnostic. By definition, a positive screen means a higher likelihood of having the underlying disorder, and a negative screen means lower likelihood of having the disorder. So it's really important to use clinical judgment if the screening result doesn't match what we're seeing in the patient's presentation or the parent's presentation. A quick note about the MDQ, the Mood Disorder Questionnaire. We won't have time to go into detail. This is a screen for lifetime history of bipolar disorder. And the reason I mention it here is that there is something unique about the perinatal period when it comes to risk for a bipolar episode. It actually carries the highest lifetime risk for first onset of bipolar illness. So women who experience the first onset of a mood episode, whether depression or manic episode, in the perinatal period have a higher risk than the general population of having an underlying bipolar illness. This is important because the treatment's different. And antidepressants, treatments that we use for call unipolar depression or major depressive disorder, can not only be ineffective, but actually can make patients worse. So before starting a medication in the perinatal period, we generally recommend screening for a lifetime history of bipolar disorder. These screens, again, they're validated in the perinatal period. All of these are non-proprietary, so meaning they're free to use. They're easy to administer, they're easy to score, and they're available in multiple languages. Screens that are specific to the pediatric setting. A lot of folks who work in the pediatric world are probably familiar with the SEEK, the Safe Environment for Every Kid. It includes, amongst a number of other screening questions, the PHQ-2 items. But rather than a Likert scale, it's a simple yes or no. So a yes on either item, we recommend administering the full PHQ-9. And then the SWYC, the SWIC, the Survey of Wellbeing of Young Children, it contains within it actually the Edinburgh Postnatal Depression Scale, and it includes it at the 1, 2, 4, and 6-month age specific forms. We generally recommend if you're a Louisiana provider and we can be reimbursed, pediatrician and pediatric clinics can be reimbursed for screening for maternal depression. We recommend just documenting that score as the EPDS score in the patient's chart. So very quickly, this is the SEEK, which asks some very important screening questions and includes within it questions about parenting stress. And as you notice, those last two items, those are actually the PHQ-2. And then the survey for well-being of the young child includes, they call it emotional changes with a new baby, but the questions are actually the EPDS. So how to implement this in a really busy pediatric practice where we're doing a number of things at a well-child visit, including vaccinations, including talking about safety, screening for the child's development. There's a lot of things that pediatricians are tasked with doing. So I'm going to go through sort of a flow chart that could be useful. And we're going to go into detail in each of these steps. But screening starts with the introduction of the screen. I think this is really important. How we introduce the screen is going to impact a patient's how they fill it out and how they view the questions that you're asking. So the introduction can be verbal. It can be a written introduction on the top of the screen. That introduction can be given by a nurse or a medical assistant. And the next step after the patient completes the screen is the scoring. And the scoring can be done by anyone in the clinic. Where the licensed clinician responsible for the patient's care that day comes in is in receiving the result of that screen, interpreting the result of that screen, documenting the tool that was used, the results, and any follow-up action in the pediatric chart in the case of a pediatric provider. And then the next step is feedback. And we're going to talk a little bit about feedback. The feedback should be given by the licensed clinician responsible for the patient's care. Some clinics are fortunate to have, for example, a social worker, somebody else in the clinic who can help address some of these needs. It is really high yield for the clinician, for the physician, for example, the pediatrician, OBGYN, the primary care doctor, to also give feedback because it sends an important message to the patient that this is part of care. And then the next step would be where we're talking about next steps to take. And this is where consultation can be helpful, and we'll talk briefly about consultation as well. whether it's a question about interpreting the screen, the patient's diagnosis, treatment options, support with referral for mental health care, and also support with community resources. So step one, the introduction of the screen. I think this is a really important piece that sometimes gets missed. Again, this can be done verbally when the screen is handed to the patient at check-in. The screen can be handed to the patient upon rooming, depends on the clinic. But something like mood changes are common during pregnancy or after giving birth, and they can impact your health and your child's health. We ask all patients these questions because it's so important that we be able to offer help. So a simple introduction that sends the message that this matters, and we're going to talk about it. The second step, the scoring. We have some guides about scoring. Scoring's pretty straightforward. I want to bring everyone's attention, though, for both the EPDS and the PHQ-9. The last item asks about suicidality. It asks about safety. So critically, it's important for the clinician not only to know the total results of the screen, but also the score on that last item, question number 10 on the EPDS and question number 9 on the PHQ-9. And because it asks about safety, the screen needs to be scored and the result given to the provider prior to the patient leaving the clinic that day. So that's why I want to bring everyone's attention to the last item. And we'll talk a little bit about safety screening as well. This is a basic guide, remembering that a screen is not diagnostic. It's just a screen, but a sense of what a positive score is, but also kind of ranges that suggest to us patients who have mild through severe depression, mild through severe anxiety. And again, on that safety screen, any score other than a 0 warrants further assessment and plan. That doesn't mean hospitalization. That doesn't mean that the patient needs to stay in the clinic that day, but it means that there needs to be further discussion and a plan put in place. Feedback. So the first note about feedback is we recommend giving feedback about negative screening results as well as positive. I think often when patients fill out these screens, they never hear about it. No one talks about it. The provider doesn't address the screen. And probably for the provider, they're looking through, seeing it's negative and saying, oh, great, so glad I can check that off my list. But they don't give that feedback to the patient. And then a feedback about a negative result is actually really high yield. It's really meaningful. It need take only 20 to 30 seconds. Thanks so much for filling out these questionnaires. It sounds like you're not experiencing changes in your mood at this time. Moods can change at any time after giving birth. So we're going to ask some of these questions again at future visits. That does a few things. One, it conveys to the patient or the parent, this matters. This is a place where we can talk about your mental health, even if not today. It leaves the door open for a patient who isn't yet experiencing symptoms, but may later, or a patient who is experiencing symptoms, but they are reluctant or not ready to talk about it today. This leaves the door open so that they can bring it up at their next visit. Giving feedback about a positive screening result. Thanks so much for filling out the questionnaire. It sounds like you've been having some low moods lately, and you may be experiencing depression. Would it be okay if we talked more about that? So getting the patient's permission. And something that can be useful, this is from the world of pediatrics. This is Larry Wisso, who has written about the common factors approach, and this is his mnemonic. But it's the HELP mnemonic, stands for hope, empathy, using the patient's language, conveying loyalty, asking permission, conveying partnership, and coming up with a plan, ideally a plan that's written down. Just an example of some language. It sounds like things have been really getting on top of you lately, if that's how the patient describes it. Can only imagine how stressful that must be. I'm so glad that you told me. You and your baby deserve for you to be well. I'm here to help. There are a few options I think are going to help you. Would it be okay if we talked about those? And then we can talk about some next steps together. So just an example of some ways to talk about difficult topics, the common factors approach, and specifically talking about a positive depression screen. I want to add here a quick note about conveying empathy. I think often we as very well-meaning clinicians may be quick to jump to identifying with the patient and to normalizing symptoms. And it can feel very validating for a new mom who's not sleeping and is ready to pull her hair out to hear her pediatrician say, oh, me too. I had the same experience. I promise you it gets better. But what if that patient isn't just experiencing the stress that comes with a newborn, but is actually experiencing clinical depression? It's going to make it that much harder for her to talk about what's actually going on for her. So we often talk about conveying empathy, validating what's going on for the patient without closing the door too early. And we can do that by saying, "You're not alone." A lot of women experience this. It's quite common without shutting the door too early on being able to talk openly about what's really going on for this patient and what her experience is. There's a lot of words on this slide, and I'm sure I've shared this slide, so I'm sure we can share these. This is just some guidance around safety assessment. I think this is a thing that makes a lot of clinicians worried. If I ask the question and the patient endorses suicidal ideation, what are my next steps? So this gives some guidance about kind of generally how we assess risk. Suicidal ideation is not uncommon in depression, and not all patients with suicidal ideation require hospitalization. Always safety first. When there's concern for imminent risk, we need to get that patient to the emergency room. But just some guidance around questions we can ask. When people are sad and down, they often have thoughts about death or wanting to die. In the past couple weeks, how often have you thought about death or wanting to die? And that's what we call a permissive statement rather than asking, are you, or you're not having thoughts about suicide, are you? Right? Which makes it hard for the patient to answer honestly, giving a permissive statement there. And kind of working our way through how we generally in mental health assess risk for harm. If there's any concern about the safety of the mother and baby, we don't leave them alone until the assessment's complete. And some language here for how to talk in a way that's non-judgmental with patients that are experiencing suicidal ideation. If ever in doubt, this is a place where you can call for consultation. We generally advise if there's any concern for imminent risk that the patient get to emergency services. Just an example of that next step in consultation, and I'll talk a little bit about the provider to provider consultation line. I do provide perinatal psychiatric consultation. This is a free program. It's open to any clinician in the state that's caring for pregnant or postpartum people and their families. Um, we're available by phone. We also have email, and I put the QR code in there for registering. We ask for folks just to register. It's a brief registration. That way we have your information if you ever call. But some of the common questions we get from pediatricians, I deal with a lot of nervous moms. I'm not sure if this is typical nervousness or if there's something else going on. I have a patient, she's breastfeeding, she's taking psychiatric medications. She's not sure if she can take them. I don't know how to advise her. We can give guidance around that. Or we also get calls that are just, hey, I'm not sure what's going on, but something just doesn't feel right about the interactions between this parent and this baby, or the interactions in the family. You don't need to have a well-formulated question or even know what your question is to call for support. We'll help you figure it out. And we do also provide resource and referral support, whether that's for psychiatric treatment, substance use disorder treatment, therapy, including dyadic therapies we'll touch on briefly, and then resources as well, including pregnancy-specific or postpartum-specific resources that families often have a need for. So I want to make a quick note about when caregivers have a primary care doctor. A patient's parent screens positive, and they say, "Oh, I have told my primary care doc, and I'm on a medication." It's okay to ask follow-up questions with the patient's permission, including, "How do you feel like it's working for you? Is that medication helping you? Are you having side effects?" And the reason this is important is sometimes moms, maybe they see their primary care doc maybe once a year. Maybe they got started on an antidepressant and just kind of haven't followed up, and it's a low dose and it's not fully helping them. We want patients to have remission of symptoms, particularly during this high-risk time. And it's okay to ask these questions and provide some basic psychoeducation. I think it's really important for you to share this with your doctor. Often medication adjustments can be made to make sure that treatment's working the best it can for you. Okay? Can consider calling the primary care doc with the patient's permission to coordinate care, because sometimes often the pediatrician who's seeing moms multiple times in that first year of life, they're going to be the ones who first pick up on this, and coordinating care with that patient's doctor can really be a critical step. I want to talk about the screening passport very briefly. This is something that also comes from the world of pediatrics. We've adapted it, and we have this for free on our website. But basically, the idea with the screening passport is it's a home for the patient's screening results. We know that the electronic health records, there's multiple different EHRs. It can be hard to access. How do we help patients communicate with their various providers about their screening results? And this is a place where they can record it. Pediatrician office can record it for them, and then they can take this with them to their primary care doctor, to their OBGYN, to their psychiatrist, so that we're able to help patients advocate for themselves and make sure that their provider knows what's going on. So again, this is available on our website. If folks have questions about using the tool, there's some guidance on the website, but feel free to call us as well. Some resources that can be really helpful for caregivers. Um, these are not treatment, but these are some helpful resources for caregivers who maybe are experiencing more mild symptoms. 0 to 3 is a great advocacy organization that provides a lot of videos on various parenting topics. The Vroom app, which is a free app, it's called a brain building app. It is, but it's also a relationship building app. And it has some great little tips for parents about ways they can interact with their child depending on their child's developmental stage. We have some resources, two-lane parenting resources on our website, so feel free to make use of those, including screening tools. The AAP's parenting website, healthychildren.org, is excellent, very trustworthy articles on a variety of topics, including parenting, including depression and sleep. And I mentioned the Fussy Baby Network has a warm line. And critically, the National Maternal Mental Health Hotline used to be a warm line. It's now a 24/7 hotline, not a suicide crisis line. That's still 988. But if a mom who wakes up at 3 a.m. and she is exhausted and she just can't get her baby to breastfeed, she can talk to a warm body, someone who's trained to field these calls and who can also help refer to resources if needed. Finally, when to consider referring to infant mental health. We won't have time to get a lot into what infant mental health is, but basically this is resources for children 0 to 6 and their parents who may need intervention. And some reasons to consider referral during pregnancy would be perinatal mental health problems, perinatal mood or anxiety disorders, parent history of trauma, an unwanted pregnancy, feeling overwhelmed, or intense ongoing family conflict. And I know pediatricians are encountering this. And then after birth, babies who are preterm or have chronic medical problems, a NICU stay or another separation that occurred, exposure to substances in utero, a caregiver is having difficulty responding to their baby's cues or making negative attributions about the infant, all could be reasons to refer to infant mental health. Our line can help with this. We can also help with these referrals, so feel free to give us a call at PPCL. The Louisiana Center for Evidence to Practice also has a list and a map of where you can find evidence-based interventions for this age group, and I listed a few here. I know we are short on time, so I'm going to stop share and turn it back to Dr. Northington.
Thank you so much, Dr. Finelli. That was wonderful information. At this time, we will be accepting any questions that we might have in the chat or the Q&A section. So let me just go ahead and check and see what we have. And Dr. Finelli, you said it was okay if we share the presentation with?
Absolutely.
Okay, perfect.
Absolutely.
So if that's one of your questions, I will be able to send it out like a PDF version to everybody to be able to get those wonderful resources. Okay, let's see. And there's a
Just put
link.
the link for PPCL if you'd like more information, but feel free to just give us a call. We're happy to chat.
Let's see. I don't see any other questions in the Q&A or the chat. But if you do, any participants, if you do have any questions after this, please feel free to send them to me or Dr. Finelli, and I can get them to her as well with any questions that you might have. Just a reminder, oh, I think I see one. Okay, we do have one. The question says, how do we know about PPD but not perinatal? They don't go hand in hand?
I think this might be referring to PPD being postpartum depression. So it's a great question about definitions. So generally, the term we often use now is perinatal depression, and that refers to depression occurring at any point between conception and through that child's first year of life. So that we consider perinatal. So that includes pregnancy and postpartum. There are some differences, but what we know is that some patients with postpartum depression actually started developing their depression before or during pregnancy. Other patients develop depression after, and that's why we want OBGYN screening and we want pediatrician screening so that we can try to catch patients during that entire perinatal period. I hope that answers the question.
I believe so. That was great. Okay, let me check again. I see any other? Okay, I do. She said yes, or he or she said yes, thank you. So I think that
Thank
was
you.
okay. Any other? If not, just a reminder, if you are seeking CE or CME credit after the conclusion of this webinar, a screen is going to pop up with the evaluation link. Please fill it out and we will get the certificate for the CE or CME contact hours or credit hours to you after the conclusion of the series. Let's see, I don't see any other questions for now. So I want to thank Dr. Finelli and all of you for attending this year's summer webinar series, and we hope to see you back again next year. Thank you all so much. Bye.
Thanks all.
Bye. Thank you.